Hello, everyone. My name is Shafiq Siraj, and we are here for the shoulder session. It gives me great pleasure to introduce Dr. Joaquim Sanchez Sotelo. He's going to talk to us about the science behind STEM in shoulders, and I'm sure he's going to show us some art as well. Thank you very much.
Thank you. Thank you very much to all of you for being here for yet another talk. We're going to switch gears compared to what was presented before, and we're going to talk about shoulder arthroplasty. And today we'll discuss some issues that have to do with the length of the humeral component in shoulder arthroplasty. These are my disclosures, and as you can see, I help Stryker to design these implants, so obviously I have a clear conflict of interest, and in fact, the opinions that I will share with you today are my opinions, and the Stryker has this disclosure slide to reflect that. So anyone that knows much about the history of shoulder arthroplasty is aware of the fact that humeral component failure has been very uncommon. So if we look at patients that had an arthroplasty of the shoulder years ago and we follow them over time, the failure rate is very, very, very low. And you can see here a patient that had an arthroplasty 10 years prior with a perfect component. However, the perception has been for a long time that these components were way too long. So in a way, it made sense to go shorter. But the problem is that we didn't know if going shorter was going to be a problem because we didn't really have a clinical issue with the conventional length stems. However, if a patient had a conventional length stem and then had a fracture, or if the patient had deformity or there was an elbow arthroplasty, obviously a very long humeral component becomes a problem. So I think it makes sense to go shorter than the traditional length. Also, if anyone in the audience has ever revised a fully coated or extensively coated stem of this length, you realize it's a bone-destroying operation. And we all have the perception that the classic length is just too long. So if you go around the academy hallway here in the exhibits, you will see that most companies have come with a short stem. But the funny thing is that, as far as I know, the length of these stems was chosen out of the blue, no science behind it. And what's happened is that we have seen problems that were completely unforeseen. So we went from a regular length stem that had a perfect clinical performance to many short stems that look nicer on x-rays on day one, but they're actually worse. And this is documented. So this is a paper by Dr. Casagrande et al. That shows a very high loosening rate at 2 years with a very short humeral component. You will see on the technique brochures of different companies that if you go really short, the distal aspect of the canal will not align the implant, and it's very easy to place the stem in either too much varus or too much valgus. And then if you look at x-rays, you see changes that are really worrisome. Look at this x-ray, for example. You can see the x-ray 2 months after surgery and then about 2 years. And if we zoom in, you can see how the greater tuberosity is starting to fade out or disappear, and the cortex on the lateral aspect of the humerus is going away, as you can see here. Another example of a patient with a reverse arthroplasty, and as you follow the patient over time, if we zoom in again, you can see how the greater tuberosity is basically melting away, like we see in fractures, and on top of that, there is a defect in the cortex that has happened spontaneously over 2 years. Another example, where if we zoom in, we can see how the fixation has happened distally and proximal to where the transition is between the metaphysis and the diaphysis, there is severe osteopenia. So when you see these adverse bone reactions, some of them are osteolysis, and that means that they are secondary to polyethylene wear, but the majority of the reactions we see with short stems that are being used over the last 5 years are secondary to stress shielding. And stress shielding is more likely to happen if you do not use titanium, if you have a really large component, and if you don't have a very high quality proximal coating, but no one knows about the length. Obviously, if you use a stem that is really short, what's going to happen is that for you to get fixation, you're going to have to make the component really wide. And having a very large fill to fit ratio is a known risk factor for stress shielding. In addition, if the implant can subside, because there is still opportunity for the stem to go distally and touch the cortex in an asymmetric way because of malalignment and so on, then that spot welding at the tip of a component will make it more likely to have a stress shielding affecting your reconstruction. And in fact, if you overlay the cross section of the very, very short stems, they are really, really wide proximally, and that's a problem. Over the last 8 years, I've been using for anatomic arthroplasty the Stryker standard length stem, and I've been doing a study that includes now about 60 patients where we have x-rays at time 0 and at 5 years. This is one example. If you look carefully at those x-rays, look at the tuberosity, there is 0 change in bone density. Another example of a patient that had an arthroplasty, you can see on your left an x-ray at 2 months, and then at 5 years, absolutely no stress shielding. So what we want to do at the Stryker is to maintain the quality of this stem, but go shorter. But how much shorter? And this is where the engineers at the Stryker, working with the design surgeons, have been able to come up with a scientific way to understand what is the ideal stem length. That is the key. The key is not to go as short as possible, it's to go the right length to hopefully get the benefit of a stem, but avoid the possibility of adverse stress shielding. So how do you do that? Well, our team took almost 300 CT scans from the SOMA database, where you can actually outline the profile of the endosteum and then overlay with the periosteal outline and get a composite of the bone, and then analyze where is the transition point, meaning we all know that the canal of the humerus is wider proximally, it's like a cone, and then it gets into a cylinder, right? The question is, where does that happen? And of course, that may happen differently in people with different height. So maybe for you who are taller, it's actually a longer distance than for you that are a little bit shorter, or for me, I'm shorter too, right? So it turns out that if you do the measurements proportionally for every single stature, the transition point between the conical and the cylindrical aspect of the endosteal canal is always about 20% of the length of the humerus. So that's one first breakthrough, because now we know where will the stem start to engage the cortex. And interestingly, in these almost 300 samples, very, very reliably, almost 20%, 22%. The next question is, okay, so how much of the stem do you need past that transition point so that the stem has stability and self-alignment? So the next study was to understand what is what we call the minimal engagement distance. How many millimeters of cylinder of the stem have to be contacting the inner diameter of the diaphysis to get you the perfect alignment? And the answer is between 15 and 17 millimeters. So if you make the math, you realize that to cover the spectrum of human beings, what you need is an effective length of 83 millimeters. Something that is important for all of you to realize is that each company measures length differently. So for example, some companies will measure the length from the deepest portion of the tranion to the end of the non-bulleted portion. So then they tell you my stem is 55 millimeters, but maybe it's actually 65 or 70. The way we measure the effective length is from the very top of the humeral component that you can see on that white line on the top, all the way down to where the stem becomes no longer cylindrical and becomes a bullet. Now, because you have to cover the whole diameter from 6 to 20, in your mind, as you project that bullet, is going to be longer for the wider stems. That's why in the table you can see that even though the effective length is about 80 millimeters for every single size, if you add the bullet, then you see an increment in length, which is proportional to the fact that the stem diameter has to extend into the bullet of a prosthesis. So we're very proud to have introduced at AOS this Reunion S stem, because we think it's going to give you what you need, which is a stem that has the right length, so that we avoid all the problems that we are seeing now with the really, really short stems. We provide primary stability, secondary to distal fit and the proximal press fit wedge. Thank you very much. Any questions?
Questions?
Thank you for your presentation. Which kind of scenario do you believe in the future about the periprosthetic fracture between the traditional stem and the conservative, the short stem?
So I think that if this stem turns out not to increase stress shielding, and then the patient has a fracture, I think it'll be easier to fix because you will have better bone quality proximally. My concern, if we go to the x-rays where we saw all this bone disappearing, is that if this patient that has lost so much bone already, as you can see on the right, then fractures, you have no bone to provide fixation. So I think it's important to confirm that what we think is going to happen. No, obviously we don't have any clinical experience, but it's very clear to me, because I've talked to many surgeons around the world, that the ultra short stems are too short. We are all seeing these reactions in the bone, and many companies are now concerned that maybe we went way too short. So I think we're going to see that we have to go a little longer, but not as long as we used to be in the 90s and the 80s.
Okay. Questions? Joaquim, thank you very much. My question to you is, these are being advertised or, promoted for younger and younger and younger patients. Now that we know the science behind it, how do you factor in patient age?
Yeah, I think older patients clearly have more osteopenia, so my prediction is that maybe 5 to 10 years from now, the majority of patients with healthy bones will get a stemless prosthesis. But if you have to use a stem, it'll be in these patients that you're talking about, and in those it's really important that the stress shielding doesn't compromise any further their decreased bone mass.
But for the younger patient, then consider stemless one, and then move that up for the short long stem.
Correct. The right length stem.
The right line. Any questions? Joaquim, thank you very much.
You're very welcome. Thank you, everyone.